All right. Assalamualaikum and a very, very good morning to everyone. Osonong Koswabon. I'm Faiz from Hospital Raja Permaisuri Bainun Ipoh, and I was given this topic, airway management. So if you talk about airway management, it is a very, very huge topic, and you can have a 1 week course on airway itself. So what I would like to touch here is not the complexity of airway management, but I would touch on the basic one, the simpler one. I think everyone knows about this, but I will add up some extra tips, tricks, and tweaks on how to improve your airway management, evidence-based, so that we can help patient better. So let's start with the presentations. So we'll continue with the outline of my presentation. So some introduction. The most important thing is the point number 2. What are the extra tips I would like to share with you guys? Some take-home messages, and last but not the least, reference if you want to read further. This is the extra tips that I would like to share with you guys. As you can see, these are all basic airway management. I am pretty sure that everyone already knew about position, adjunct, airway opening, and everything. So what I would like to share with you guys is the tips on how to actually improve your basic airway management and knowledge so that you can bring your airway management to a better level. All right, as an introduction, sorry for the interference again. We know that the mantra ABC, 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 airway and oxygenation should be at the top of your list, the first priority of everything. So we know it is very important, but it is not as simple as it sounds because it ranges from the spectrum of basic to advanced airway. More importantly, we have to follow a systematic stepwise approach so that our airway management is better that way. Yeah. And of course, now in this modern era, we have to go into the paradigm shift from a more traditional airway management to a evidence-based literature suggested modality.
I tried the right project ni. So dia kena buat 20 bungkus kopi
And
tapi labas dulu.
let's go to the tips. Tips number 1, patient positioning. Yeah. So this is as simple as it sounds. Yeah. And you can see from the picture, this is a coffin picture. Why do I put this coffin picture? Because this is the worst position that you can put the patient into. Yeah. Coffin position is actually cannot oxygenate when your face is flat and neutral position. Basically, you are putting the patient on supine position, which is not good at all. All right. Why? Why is lying supine is not good? Because what will happen is that your tongue will fall back, your soft tissue and upper airway will relax, it will compress your airway, and your chest and diaphragm will be compressed as well, reducing the lung capacity, reducing the oxygenation as well, and intervention is more difficult when patient is lying flat. So why is patient positioning is very important, and I put it as the first step because you want to create a patent airway. This is the main aim of your basic airway management. So how to create a patent airway? By a 3-step process. Number 1, positioning. Number 2, adjunct your OPA and PA, and then your jaw thrust. So basically, this is the 3 things, and you can see that positioning is at the top of the list. So it is important because the more open the airway is, the pressure and the volume required for effective ventilation is lower and reducing the risk of aspiration. And you have 3 optimum position you can choose from, not the coffin position, but your sit-up position or your sniffing position, and last but not the least, head elevated position. All right, first and foremost, your sit-up position. This is basically the best position you can put your patient in, because if patient is able to sit, please put your patient in sit-up position. Just remember, oops, oxygen on, pull the mandible forward, the jaw thrust, and sit the patient up. And the model here is smiling because the airway is more patent now. So your sitting up position will improve your overall airway management. So you don't want the sit-up position, for example, and patient is not able to sit up. Next, you have the sniffing position. So basically, sniffing position is you do it by you place a pad under the head, and basically you make sure that the external auditory meatus is at the same line as your sternal notch, and you extend the head at the atlanto-occipital joint. And what will happen is that you are actually aligning all the axes. We know we have the three axes, the oral axis, the pharyngeal and laryngeal axis. So basically what we are doing is that we are putting all the axes in a more aligned position. Can you hear me now? Some interference again, I think.
Can, sir. Can.
All right, so this is to compare your lying flat position and your sniffing position. You can see that in coffin position, you are actually aligning all the axes. See, in the coffin position, all the axes are separated. But when you put the patient on sniffing position, what will happen is that you are putting the axes in a more aligned position so that it opens up the airway, allowing more laminar airflow and less resistant to the air. So you don't want the sniffing position, you can choose this one, head elevated position. This is actually similar to your sniffing position. The only difference is that it is not extended. Your face is parallel to the surface on the patient, which the patient lies on, and then make sure the auditory meatus is at the same level of your sternal notch. This is other position that you can choose. All right, so you have so many positions, which one to choose? So best is sit up. If patient is able to sit up, please put the patient in sit up. Oops, oxygen on, jaw thrust, and sit up the patient. If not, of course, every individual is different. Anatomy is different variation. Yeah, so it is good to know different other position. Yeah, all right. But of course, we have caveat. In trauma patient with potential spinal injury, patient needs neutral position. All right. Next is tips number 2, which is your airway adjunct. So as simple as it sounds, I call this the forgotten duo because people always forget to use this thing, which is your NPA and OPA. It is very simple, but people tend not to use this. Okay, I have to emphasize why I put this as my tip is that I think use should be a standard of oxygen use if indicated, because you know, in unconscious patient, muscle tone will decrease, your hyoid bone will be displaced posteriorly, and then this will actually occlude the oropharynx. So your OPA and NPA will allow a more effective ventilation. So the tip here is that some people may only use one, but you can actually use both. You use your OPA and NPA at the same time, and this has been shown to be the more effective strategy to maintain a patent airway. But of course, we have caveat. Patient with gag reflex, semi-conscious, do not use OPA. You can either choose your NPA. All right. Next is your opening airway maneuver. You have the popular head tilt chin lift and your jaw thrust. So the misconception here that we already know is that head tilt chin lift is for non-trauma, jaw thrust is for trauma. So this is a misconception. Basically, you can use jaw thrust for every single case. Yeah. All right. So basically, what we are doing now during back valve mask is that we are giving the seal, and then we do jaw thrust. So little did we know that we are actually using jaw thrust in also non-trauma patient. Yeah. So jaw thrust, what it does is that it displays the mandible anteriorly. So it lifts your tongue up and the oropharynx so that it prevents airway occlusion. Now the preferable method to open your airway is actually your jaw thrust. Yeah, all right. We can see from this picture of this X-ray, your head to chin lift, picture number 1 and 2, it doesn't really impact your upper airway, in which your jaw thrust is shown to increase the patency of your airway. So jaw thrust is not only for trauma, you can actually use your jaw thrust in any other case. Yeah, all right. So next, tips number 4, which is your muscle. How to properly do your muscle. So this is the popular CE technique and two thumbs down technique. So which one is best? So muscle is very important. This is the CE technique, the popular one. Of course, it is good when you are alone. You want to do the seal and you want to back, you are alone. But the more preferable method now is the two thumbs down technique. In CE technique, what you do is that you use your two index and thumb to create a seal, and then you use your 3 fingers to actually lift up, and you are actually separating your fingers. So it will be very tiring. You try for 5 minutes. But the two thumbs down, why is it more preferred? Because you are resting your thumb comfortably on the mask, creating a good seal, and then you are lifting your jaw with your 4 fingers. Next. So basically what is happening, we can see from this picture, this young lady holding the ventilator with only 3 fingers is tiring. With 5 seconds and she's tired. But the young gentleman holding with 4 fingers, he's more comfortable and he's holding onto the ventilator for 2 hours. So meaning that this is your CE mask on the left, and your two thumbs down technique, your two thumbs down technique is much better. So talking again about good mask seal, use your two thumbs down technique, less tiring, and actually you can identify the leak by using the two thumbs down. You can identify the leak and manage it, and now it is proven to be more effective. Next tip is our ventilation. And this is basically a cornerstone. Why I put a cornerstone? Because actually cornerstone is the important part of the structural part of your building. So it determines the integrity and stability. So basically what I want to say is that ventilation is cornerstone of airway management. If you don't know how to ventilate, then your airway management will fall apart. So talking about ventilation, you have several techniques. You have BVM, your common BVM, and you step up a further bit, your BVM plus your PEEP valve, and then patient is still hypoxemic, you want to use VAPOX, ventilator assisted pre-oxygenation. So we'll go one by one. BVM ventilation. So it sounds simple, but do we really know the proper technique of doing back valve mask ventilation? Our aim is simple. We want to have adequate oxygenation, and then we want to prevent the adverse effects of overventilating, like increase in intrathoracic pressure, avoid regurgitation, hypotension, and etc.
Okey, dia kata kat sini, bagaimana positioning untuk intubate patient? Adakah perlu sniffing position juga?
Hello, can you hear me?
Okay, yes.
Yes, most important in intubating patient is always the position itself. And of course, your sniffing position create a more patent airway. You are aligning the axis in a more, a better alignment of the axis, so it is better. So you can actually intubate with sniffing position. It opens up the airway more, so it is better that way. You can also choose the head elevated position, more or less the same. The only difference is that you don't extend the atlanto-occipital, because some people might find that when you extend the atlanto-occipital joint, it will actually interfere with the view a bit. So you can choose either one that you are comfortable with and best for the patient.
So I hope the doctor answered the question. Okay, we have another question also, doctor. This Nur Azman Lahab would like to know is RSI method is crucially applied in emergency facilities setting? So I repeat again.
RSI.
Okay, is RSI method is crucially applied in emergency facility setting?
RSI is rapid sequence intubation, you mean? Yes, rapid
Yes.
sequence intubation is, oh, okay. So basically, yes, we use RSI in in any of our patient in emergency department particularly, but I'm not too sure what you mean by RSI. Which component are you pointing out? So if possible, you can actually rephrase your question and I will answer later.
Please, Mr. No Azman Lahab, is it possible for you to rephrase the question so that Dr. could answer your actual question? Cricoid pressure. Prevent the
cricoid
stomach
pressure.
content into the airway. All right.
All right, I will talk about cricoid pressure. After this, I have in my tips number, I think number 6 or 7. But cricoid pressure is no longer used routinely unless in some circumstances, unless, like in patient with risk of aspiration, in morbidly obese, for example, we can use, but it is no longer practiced in during RSI.
Okay, so I think we're back on track.
Yeah, you can see the slides now.
Yes, Doctor, proceed.
All right, sorry again. So let's continue with BVM ventilation. So again, our aim of ventilation is simple. It is to provide adequate oxygenation without risking the patient of the side effect like a regurgitation, a hypotension, and etc. All right, so we have to know what is the correct technique. You don't simply bag. If you just simply bag, you are risking the patient of complication, which is not good. So basically, you need to have optimal airway opening. I've told you about that before. And when you bag, use a longer inspiratory time. You use 1 to 2 seconds to bag. You don't have to be so enthusiastic to bag very frequently. Yeah, and of course you use smaller tidal volume, just enough to achieve a chest rise. You don't have to bag like compress the whole bag because you know it contains like depends on the bag 1.5 liter up to 2 liters. If you bag whole bag, so there will be burst of the patient lung, which is not good. And number 4, you have to ventilate at the lowest rate possible. Probably 8 to 10 is enough just to achieve SpO2 of more than 94. That is enough. So again, longer time, smaller tidal volume, and lower rate. That is best. So of course, we have caveat in patient, like in cardiac arrest. Of course, you have the predetermined rate, the 30 to 2 if patient is not intubated. And in intubation, of course, the rate would be every 6 seconds. Yeah, all right. So next, you step on another level. Patient is still hypoxemic. You want to use this tool, which is your PEEP valve, which is very, very good. So basically what this PEEP valve do is that it provides continuous pressure. So when you add up a continuous pressure to the patient, so it improves the oxygenation. But the problem with PEEP valve is that when patient is not breathing apneic, it won't supply PEEP, yeah, unless you manually bag. So the tip here that I would like to share with you guys is that you want to add a continuous flow, yeah, during using your PEEP valve, because when you are using a continuous flow, regardless of patient breathing frequency, you will actually give a continuous PEEP. Okay, you step up to another level, which is your VAPOX, ventilator assisted pre-oxygenation. So what is it? Basically, as the name implies, you're using ventilator to pre-oxygenate. Who is eligible for VAPOX? Basically, you use it in patient who is hypoxemic. You want to give a continuous PEEP, you can use this. But actually, it can be used in any patient because you are controlling what you want to give to the patient via the ventilator. You control the PEEP, you control the rate, You control the volume, yeah, which is quite good. So it prevent and reduce the risk of aspiration. So how do you do it? By VAPOX protocol. VAPOX protocol depends on the centers. We have many protocols, but I will share with you guys the simplest one. You can use SIMV non-invasive FiO2 of 1. Low rate, again, 6 to 8 enough. PEEP 5 to 15 and not exceeding that because it is associated with gastric insufflation if you pass through this threshold. Tidal volume 500 to 550 ml, and inspiratory flow, you reduce it because you want to increase the inspiratory time to increase the mean alveolar pressure to improve the oxygenation. So this is one of the protocol. Tips number 6, apneic oxygenation. Okay, basically, this is a procedure in which you want to increase the safe apnea time. Basically, a simpler word of this safe apnea time is that when you start to intubate and patient is still not desaturating, patient is still okay, that is the safe apnea time. And apneic oxygenation is to extend the safe apnea time so that patient won't get hypoxemic. So to do it very simple, you just put nasal prong 15 liter during RSI. It will create a gradient and reservoir, extra reservoir, and it is good to use apneic oxygenation. Pre-hospitally, they may ask, okay, it's quite difficult because I have only one oxygen tank. So while I'll beg, how can I do apneic oxygenation? So it's simple. You just put your oxygen nasal prong on, and then when you disconnect the back valve mask, when you are about to intubate, you connect the nasal prong to the oxygen tank. So that's it. Yeah. So as simple as that. So next is ELM, the external laryngeal manipulation. So I think everyone knows about this, but I want to clear some misconception. So this is not cricoid pressure. Yeah, cricoid pressure is basically just pushing your cricoid backward to prevent aspiration, which is not longer routinely used unless in patient with higher risk to develop aspiration, like in severely obese, for example, in pregnant, for example, but it's not routinely used. Yeah, but what I'm going to give you a tips about ELM, laryngeal manipulation. You don't push on the cricoid, but you actually manipulate the larynx. So you can do it by two ways. Number one, by manual laryngoscopy and your famous burp procedure, your backward, upward, rightward pressure. So basically what we are doing, we can compare both. By manual laryngoscopy, as the name implies, you are using both hands. One hand, you hold the laryngoscope, the blade. On your right hand, the one who is intubating is manipulating the larynx. And yeah, this is the best view. And then you ask the assistant to take over, and then you intubate. This is the best and preferred method by manual laryngoscopy. Remember, this is not cricoid pressure. This one, you manipulate the larynx. Burp maneuver, another popular procedure, is that you are actually returning the larynx because during intubation, you are actually causing some distortion. The axis is no longer at the correct position. So you do this burp to actually return to larynx to its original position. But of course, the downside, it is blindly done by your assistant. So it is recommended to do the bimanual laryngoscopy. Tips number 8, your ETT Introducer. It may sound fancy, but it's actually just your buji. So why I put buji in one of my tips? Because it is always forgotten, like your OPA and NPA as well. So basically, when you talk about buji, it is simple, it is inexpensive, and your intubation rate is improved using buji from 66 marginally increased to 96%, which is very, very good. So my tip is that please have your buji ready at any time, any intubation. Because now the reality is that when you're intubating a normal patient, okay, we don't expect difficult intubation, so buji is not there. So when sometimes you encounter difficult intubation, you ask for buji. and your assistant have to run all over department, find buji for 5 minutes, and this is not good. So the tip is please have your buji ready at any time, any patient, any condition, and any intubation. Yeah. And last but not the least, ETCO2 or ETCO. Some call it ETCO2, some call it ETCO. You can use this to confirm your ETT placement. Basically, this guy is showing the capnography. You have to know about the capnography and the normal level between 35 to 45. And basically, what I want to share with you guys is using ETCO to confirm ETT is recommended by the American Heart Association, Class 1 recommendation. It says the most reliable method to confirm correct placement is actually your ETT, your ETCO, basically, plus your clinical assessment. Because traditionally we are using the 5-point auscultation, which is actually notoriously inaccurate. Because when you are intubating the esophagus as well, you can hear some lung sounds. And sometimes you are not sure. You ask other person to listen. Hey, I'm not too sure. Can you listen? So it takes time. So now the best method is, of course, using ETCO plus your clinical assessment. And of course, now we have our ultrasound, which is very readily available. And if you know how to do it, using ultrasound in your airway is the best method as well. All right. So I think that's it about all the 9 tips I have shared with you guys. I will give you guys a summary on on all my tips, and I will present the summary with a case. Yeah. So I have a case. A 55 years old gentleman, IHD, hypertension, complained of SOB. So you responded to the case. Patient was tachypneic, RR was 45, SpO2 low, and you put on 15-liter high flow mask, and patient suddenly developed respiratory arrest. Pulse is still palpable. So how would you manage the airway? You need the intubation. All right. So basically, I will answer myself. So first of all, do not panic. Yeah, do not panic. Be calm. Next is you put patient on head elevated position, or you can even put on sniffing position, and then you insert your adjunct, and then you do proper mask seal using your 2 thumbs down. Yeah, and then you back with a proper technique, which is low rate, and then a higher time, and just enough for the chest to rise and fall. And then of course for apneic oxygenation, you actually put your nasal cannula on. Yeah, and if you have one tank, I've told you about this before. Yeah, and then once ready, you are ready to intubate, you connect the nasal prong on, and then you use laryngoscope with bimanual maneuver to optimize your view. You ask your assistant to take over. You use buji, you insert your ETT, and to confirm it, clinical assessment plus your ETCO. And this is the best method. And voila, now you can send your patient to the health center. So I hope I have summarized all the tips I've given to you. Although it's very, very basic, I think I have added some tips here and there. I hope it can tweak your airway management, the basic one, and you can have a better airway management after this. So I hope that I hope you enjoy it and be more practical. And these are my reference if you want to have further readings. With that, I thank you very much, Ponsico, and see you again.
Thank you, Doctor, so much for interesting sharing.